Hi, my name is KEAT and today I'm the leader of Group 3 and today our group is going to discuss about anxiety, depression and also suicide. The presenter today consists of Lim Siquan, KEAT, Sid Infant, CHEE, and No NABILAH, FILZA, BINTI, NURHAMAN. I'm going to talk about an introduction to this topic. So what exactly lead to anxiety, depression and suicide? The COVID-19 pandemic has contributed to increasing levels of anxiety, depression, and other symptoms of stress around the globe. Reasons for this increase are understandable in the context of individual level factors such as self-isolation, lockdown, grief, survival guilt, and other factors, but also broader social and economic factors such as unemployment, insecure employment, and resulting poverty, especially as the impact of 2008 recession are still being felt in many countries, further accompanied by social isolation. For those who are actively employed because of fear of job and income loss, and those who have actually become ill and recover, or those who have lost family and friends to illness, it is not surprisingly they are stressed and feeling the psychological impact. Furthermore, multiple uncertainties contribute to the sense of anxiety. These fears are and losses are major immediate stresses and undoubtedly can have long-term implications on mental health. Economic uncertainty combined with a sense of feeling trapped and resulting lack of control can contribute to helplessness and hopelessness, which lead people to suicide. Next, I will pass to Yingfen.
Thank you, Kaikit. My name is Sid Infant. Now I'm going to present about the underlying basis of anxiety, depression, and suicide. Firstly, the underlying basis of anxiety. Physical symptoms which indicate overactivity of the automatic nervous system, such as rapid heartbeat, increased muscle tension, such as like feel like tight band around the head, and excessive sweating. So anxiety disorder goes beyond the regular nervousness and slight fear you like may may feel from time to time. Okay, the and also the anxiety disorder happens when it interferes with ability to um, function and often overreact to some things triggers with triggers our emotion and can control responses to situation. So next, the underlying basis of depression. The symptom of depression uh, divided into two, which is psychological and somatic. Uh, Psychological includes the persistent lowering of mood with low self-esteem, hopelessness, and helplessness, and thoughts of suicide and irritational ideas of guilt and self-reproach. Okay, so next is the somatic symptoms or biological symptoms, which include loss of drive and energy. So next, there is also a loss of sense of enjoyment. The patient's mood may be significantly worse in the morning and improve somewhat as days goes on. So the third one is the underlying basis of suicide, like stressful life events such as the loss of loved one, legal troubles or financial difficulties, and interpersonal stresses may also contribute to suicide risk, such as harassment, bullying, and or relationship troubles. And especially when they occur along with suicide risk factors. And the warning signs that someone may be at immediate risk for attempting suicide include taking great risks that could lead to death, such as driving extremely fast or always talking or thinking about death. So next is the other serious warning signs that someone may be at risk for attempting a suicide include displaying extreme mood swings, like suddenly changing from very sad to very calm or very happy. And second one is making a plan or looking for ways to kill themselves, such as searching for uh, lethal methods online and stop peeling pills or buying a gun. It's like they will try to search like the ways like to end their lives and kill themselves. So that's all from my part. Next, I will pass to Yi.
Hi, I'm Yiqing. So now I'm going to describe the changes in normal bodily functions from a biochemical and physiological aspect that can potentially lead to the disorder or disease. For the biochemical changes, family studies shows that relatives of patients who have major depressive disorder have an increased incidence, which is 2 to 3 times more of depression compared to relatives of controls. Twin studies shows that increased incidence among monozygotic twins compared to dizygotic twins, which is concordance among monozygotic twins around 50% and concordance among dizygotic twins, which is 10% to 25%. Adoption studies shows that biological children of affected parents remain at an increased risk of a mood disorder, even if they are rare in non-affected adoptive families. So for the first one of the biological factors is neuroanatomy. It is the prefrontal cortex, which is responsible for social emotions. The limbic system consists of amygdala, hippocampus, which is reduce the volume in depression. This area is associated with learning and memory. Hence, depressed patients are prone to cognitive deficits or dementia. Third one, mammillary bodies. Fourth, cingulate gyrus. The fifth one is the fornix, and the last one is the purpose sequence. It's a major pathway in the limbic system. The second biological factor is the neurochemistry, which is it can decrease the neurotransmitter levels in depression, such as serotonergic system, which reduce the tryptophan, norepinephrine system, dopamine system, GABA, gamma aminobutyric acid, glutamate, altered glutamate, or glutamine ratios. The next biological factors is the neuroendocrinology. Various neuroendocrine dysregulations have been reported in patients with mood disorders. The abnormal regulations of neuroendocrine axis may be a result of abnormal functioning of biogenic amine containing neurons. The major neuroendocrine axes involved in mood disorder are thyroid, adrenal, and the growth hormones. The next biological factors is neuroimmunology. For the neuroimmunology, the focus of immunological research on MBD is on cellular immunity, especially on cytokines. These studies suggest that inflammatory cytokines can lead to the pathological behavior in depression. In depressed patients, there is an increased systematic inflammation reaction also. The next biological factor is sleep abnormalities, and it is the findings on EEG of depressed patients, which it will decrease the rapid eye movement latency, the time between falling asleep and the first REM period. It will delay on onset of sleep and also increase length of first REM period. So now we proceed to the physiological factors. The first physiological factors is premorbid personality types. Patients with histrionic personality and obsessive compulsive personality disorders tend to become more depressed as compared to patients with paranoid personality or antisocial personality types. And for the coping skills or the mechanisms, those that are experienced as reflecting more negatively on the patient's self-esteem are more likely to produce depression. And the second physiological factors is the life events and environmental stress. A long-standing clinical observations that has been replicated is that stressful life events often precede episodes of mood disorders. One theory is that the stress accompanying the first episode results in long-lasting changes in the brain biology. These long-lasting changes may produce changes in the functional states of various neurotransmitters and interneuronal signaling system. They may also cause loss of neurons and reductions in synaptic contacts. As a result, a person has a risk of undergoing subsequent episodes of mood disorder even without a stressor. The most compelling data indicate that the life event most often associated with depression is the loss of a parent before the age of 11, whereas the environmental stressor most often associated with the onset of an episode of depression is the loss of a spouse. And the last one for the physiological factors is the learned helplessness. A theory developed by Martin Seligman, a phenomenon that occurs when people or animals become conditioned to believe that a situation is unchangeable or inescapable. A learned behavior which is not an innate trait, which occurs after repeated failures at an attempt to do something. And over time, the person believes that he or she has no control over it and just stop trying.
Thank you, Yiqing. I'm KHEN. Now I'm going to present the medical test that can be used for detecting anxiety. One of the medical tests is Zone Self-Rating Anxiety Scale, SAS, developed by William W. K. Zone, MD. The SAS is a 20-item self-report assessment tool. The user scoring in 4 types of symptoms to determine anxiety levels, which are cognitive, autonomic, motor, and central nervous system symptoms. Within 1 or 2 weeks prior to taking the test, a person should specify how much each item applies to him or her when answering the statements. Each question is graded on a 1 to 4 Likert scale. To prevent the problems of set response, some questions are framed negatively. The total score is used to judge the overall performance. The raw score range from 20 to 80. After that, the raw score must be translated to an anxiety index value. The anxiety index score can then be used to determine the clinical interpretation of one's levels of anxiety using the scales when 20 to 44 is normal range, 45 to 59 is mild to moderate anxiety levels, 60 to 74 is marked to severe anxiety level, while 75 and above is extreme anxiety levels. So next slide is the sample of the SAS. Okay. Next is the Hamilton Anxiety Scale, HAMA. It was first published in 1959 by Max Hamilton. Only severe or incorrect anxiety is addressed for therapeutic purposes and the purpose of this measure. This scale is a clinical rating of the severity of anxiety and is designed for people who have already been diagnosed with anxiety neurosis. The 40-item scale that takes 10 to 15 minutes is used to determine the intensity of a patient's anxiety. Each item is scored on a scale of 0 to 4, where 0 is not present, 1 is mild, 2 is moderate, 3 is severe, 4 is very severe, with a total score range of 0 to 56, where less than 17 is mild severity, 18 to 24 is mild to moderate severity, and 25 to 30 is moderate to severe. Next slide is the sample of the HAMA test. Okay, next, back anxiety inventory, also one of the medical tests used for detecting anxiety. BAI is a 21-question multiple choice self-report inventory developed by Aaron T. Beck and his colleagues to assess the intensity of anxiety in adolescents and adults aged 17 and up. The question is in the test asks about frequent anxiety symptoms that the participant has experienced in the previous week. So it is intended for those who are 17 years old or older and takes 5 to 10 minutes to finish. And the BAI has been demonstrated to be a valid assessment of anxiety symptoms in children and adults in several studies. The BAI consists of 21 questions, each with a score ranging from 0 to 3, where 0 is not at all and 3 is very or severely. Okay. More intense anxiety symptoms are associated with higher overall scores. So the following are the standardized cutoffs. 0 to 7 is minimal, 8 to 15 is mild, 16 to 25 is moderate, and 26 to 63 is severe. The BAI has been chastised for focusing mostly on somatic anxiety symptoms. So as a result, it's frequently used in conjunction with the pen-stick worry question A, which provides a more accurate assessment of the cognitive aspects of anxiety, such as worry, catastrophizing, and so on, that are typical in generalized anxiety disorder. So the next slide is the sample of BAI. Okay, another medical test is State Trait Anxiety Inventory, STAI, by Charles Spielberger, R.L. Gorsuch, and R.E. Lushing. So the STAI is a widely used tool for assessing trait and state anxiety. It can be used to identify anxiety and distinguish it from depressive disorders in clinical settings. It is also a common sign of caregiver distress in studies, and the test takes 10 minutes to complete. It has few versions, and the most popular version, Form Y, comprises 20 items for measuring trait anxiety and another 20 for measuring state anxiety. So it's on a 4-point scale, and each item is rated like 1 to 4. For trait anxiety is not at all, somewhat, moderately so, and very much so, while state anxiety is almost never, sometimes, often, and almost always. So the greater anxiety is indicated by higher scores, and the range of scores is 20 to 80, while the cut point is 39 to 40, while 54 to 55 for older adults. So the next slide is the sample question of STAI. Okay, so the last example of medical test is Hospital Anxiety and Depression Scale, HADS. The HADS, created by Zygmunt and Smith, is widely used by doctors to assess a person's anxiety and depression levels. The question A has 7 anxiety questions and 7 depression questions, and it takes 2 to 5 minutes to complete. So the scoring is 0 to 7 is normal, 8 to 10 is borderline abnormal, and 11 to 20 is abnormal, which is the case. Okay, so below is the sample of the HADS question. So that's all from me. Now I will pass the mic to Nabilah to conclude. Thank you.
Thank you, SWEE. In conclusion, life is not easy and some people cannot handle the pressure. Anxiety and depression are two disorders that are very difficult to fully comprehend and even talk about it sometimes. Anxiety could impact physical and mental health due to rapid heart rate, palpitation, and chest pain. Anxiety disorders have been found to significantly lower quality of life, while depression is a mood disorder that causes persistent feeling of sadness and loss of interest. Sufferers may have trouble doing normal day-to-day activities, and sometimes they may feel as if life isn't worth living. Many factors can increase the risk for suicide and protect against it. Suicide is connected to other forms of injury and violence. That's all from us. Thank you.